Thank you, Emma. What an amazing number of projects. It made me think while I was there, in Australia we have a TV commercial for a product, and the slogan is, "From little things, big things grow." And I think that epitomises all those projects that you've got. So you start with a spark and you just build from there. All right, now we're going to hear from Maxine, hear all about what's happening in the Mekong Delta.
Good afternoon, everybody. I hope you hold on to your seats because I've got to take you on a tornado ride to another part of the world, which we haven't really heard much about today, to where a lot is happening, but also to talk about closer to so the elimination agenda and post-elimination, that prevention of re-establishment of malaria, because that's the end goal. And I was glad to hear Philip talk about magic and Rotary, and I saw Emma had a little symbol because I'm going to use the yellow brick road as the road to eradication because malaria is a wicked problem. So, before I get there though, I really want to, although I am now retired from James Cook University but still do work with them, a lot of what I'm talking about is the work I do as a volunteer with a civil society platform for health equity and inclusiveness, so that little emblem you see at the bottom, which represents 60 plus NGOs, civil society organisations and community-based organisations in the Greater Mekong region, which yesterday I realised not everyone knows where that is. So that's Yunnan province of China, Vietnam, Cambodia, Laos, Thailand and Myanmar, because the Mekong River flows through all of that and things flow into there. And so that's really what I'm talking about, and the work and the things I'm learning from communities, from community-based organisations about how we need to sustain the gains that are being made. So very quickly I'm going to go through these because I was given two tasks, one to bring the Greater Mekong and the elimination agenda here, and also to talk about what Rotary could do and has been doing in that region. So it is a whirlwind ride. And so we'll quickly go through some of these aspects of the agenda. All images that I show you here of individuals have also given their permission for these to be used and to be used in advocacy work. I won't read this out, but I do want to remind you of there are strict definitions of what these terms mean, and often people use eradication when they're really meaning elimination. Eradication is it's nowhere, anywhere in the world anymore. Elimination will be in a country. So China did eliminate malaria. Australia eliminated it in the early 70s. The mozzie's still there, the mosquito's still there. Sri Lanka eliminated it despite civil wars. So, but you have to prevent re-establishment until there's no malaria parasite being carried by mosquitoes anywhere and getting into people to sustain transmission. Very quickly, so what's happened in the Greater Mekong Subregion? And you sort of saw this map earlier today. What I wanted to point to you is all that red area that's there in Southeast Asia. So above Australia, if you go north-northwest, that's where the Greater Mekong is. And that was 2009, all red. This is the first quarter of this year in the Greater Mekong Subregion. On your left-hand side is for Plasmodium falciparum, and the colour areas show you where there are any cases of Plasmodium falciparum in this last quarter this year. And what you see is it's predominantly all in Myanmar, those of you who have got your geography straight, and a bit along the border with Thailand in Thailand. And the right-hand one is Plasmodium vivax, because as you get closer to eliminating malaria, vivax becomes a big problem, probably also as we get more sensitive diagnostics. Malaria ovale we're finding, and we also have Plasmodium knowlesi as a potential problem for certification as being in eliminated areas. And the density of the colours show you, again, the depth. If you could read all the numbers there, though, in the Plasmodium falciparum, you could almost know the names of the families. So in Vietnam, it's basically 2 villages in very North Vietnam on the border with Yunnan, and a little bit of an outbreak that occurred in central Vietnam. In Cambodia, it's about 40 cases along the fringe. So it really has come down. So what's required? And again, I'm not talking about magic bullets like Stephanie talked about. I'm talking about the little red shoes. What do we need to do eradication? Oh, what I wanted to show you on that previous slide too is Thailand was close to getting elimination, but the spillover, like Stephanie talked about this morning, that's happened in Venezuela. The civil war in Myanmar has caused now western parts of Thailand to be back on a control agenda, no longer on an elimination agenda. So that's very important to also keep thinking about. Philip talked about that too. So again, I won't read these out, but you can see there's a long list here of things you need, not just for control, but to get to elimination and to continue preventing re-establishment. Some of the things, people this morning, particularly because it is the case in Africa, that what you're wanting is quick response, particularly with a community-based approach and community health workers and volunteers to try to prevent people dying. You still need that close to elimination and prevention of re-establishment, because you want to know as early as possible when there's a case to stop further transmission. So it may not be now about deaths, and death rates in the Greater Mekong have, except I can't talk for Myanmar, have dramatically reduced. We have not had any deaths in the Greater Mekong, except what might be happening in Myanmar, since 2018. But we still have to keep that alert community-based response to be able to prevent the re-establishment. And until we've got that global eradication, you've got to keep this happening. And we've talked a lot about difficulty in sustaining finances and sustaining political commitment. It gets harder when there's zero, like in polio. When there's no cases, you still need to know that there's no cases. And you still need to sustain this infrastructure to be able to prevent that re-establishment. And the populations we're dealing with are really the hard to reach with routine health services. Those populations themselves don't think they're hard to reach. They have to do it all the time. Walk those long, long miles up slippery, wet mud roads, which I do. I go and visit those to actually see what their reality is and bring that reality to the donors' tables and often the national government tables. So you're talking about people in forests. Often people may be doing illegal forest work, but often that is also for their family livelihood and for food. You're talking about people who are crossing borders that were artificially determined by colonial masters, but ethnically, these are families that live across these. These are people who always have worked and lived across those borders. You're talking about people who are mobile to get work during plantation season and then go back to other parts of their country where there isn't any malaria. So you have to have strategies that get there where the people are. And you've heard that a lot today around the control agenda. It's also very, very important for the elimination agenda. These are the last pockets of malaria in these regions. They tend also to be predominantly males aged 15 to 49. So a different set of people you've got to talk about, different strategies about behaviour change communication, but it doesn't mean they only are, and one of the things I would ask all of you when you're collecting any data is make sure that it's gender disaggregated. Because people were saying to us, no, women, we don't need to worry about women and children. But when you start disaggregating the data, women, of course, also go to the forest with their husbands, often taking the children. They forage for mushrooms, maybe not chop down trees, but they still go to the forest. And so you need to know who really these people are, otherwise your strategies are going to fail. And this one is complicated, but again, no matter how good all of the strategies that we've talked about and these innovations or current tweaking of tools, you get a decay from something that might be 98% efficacious at the top. If you don't have good access, good diagnostics, good compliance providers who know what they're doing, are motivated to do their work, patients who are actually supported to adhere to the medications, then you're only going to get 37% effectiveness. This was an example from Tanzania. And often people forget this, and along all of this, communities and community health workers play major roles, as does sustained financing and sustained commitment. So partnerships, which is really the title of what I wanted to talk about, with communities and civil societies. We've already heard this morning about the things that Rotary can do, and Rotary is a civil society organisation, probably the biggest one that's now wanting and working in malaria. And so advocacy, consultation, providing information, operations, partnerships, accountability, and we heard that this morning, and really using not just your financial resources and your person, time and commitment, but using your connections, using the skills, the other technical skills that you have amongst your membership to really help pull all of that together for this agenda. So in the Greater Mekong, there's a lot of community-based workers. About 35,000 or more. You can see in Myanmar, if it wasn't actually for those community-based workers, there may not be any services provided. So there's more than 11,000, 12,000, who are the only people providing services to remote rural populations, people hiding in forests and crossing borders. So a very important strategy in the elimination agenda. They provide services to people in remote settings. They do decentralised core test, track and treat. They're a very trusted communication source, and these are people who are of those ethnic, because these are often ethnic minority populations, speak different languages, have very poor education because they're discriminated against anyway for everything. And so these are from those populations, speak that language, know that culture, and are trusted, particularly for populations who may feel reluctant to go to government-based services for other things that may happen to them. Not just security issues, but discrimination and stigma. They have to now deliver an integrated package of services, and one thing that was done, I'd say, poorly, except for originally in Myanmar, was this was taken as a malaria standalone program. Now we're talking about integration. So don't, when you already have an integrated community-based workforce, don't let anyone make you make it malaria alone. Because now we're trying to do that, and there's so much reluctance amongst government departments, etc., to give up all those resources they've had and work with others, that it's really quite hard to do this. The communities want that. The community-based health workers want that, because they're, in some places that I've been, the only health worker there is someone who can do malaria test and treat and does nothing else, even though people are dying from diarrhea. They don't even have paracetamol, don't even have oral rehydration therapy. That is unethical. So don't let anyone make you go to a standalone malaria program. So, as I've said, it's pretty hard to hold on to those gains because of those strong winds of change that both were raised by Philip and the things we've been talking about over the lunch period. I showed you what you need for malaria, and it is like those pyramids in Spain where people, you've got everything, all depends upon everything else. But any one thing is missing, under-resourced, loses commitment, the whole tower falls. That is what you need to think about. It is a partnership of many different parts, and they're all interrelated and depend upon each other. Because otherwise, and Philip mentioned this himself without showing the graph, and every time foot has been taken off the accelerator, when funding goes, when there's changes in effective strategies being implemented, when you have poorly decentralised programs, when you have civil unrest, as soon as that happens, malaria comes back with a vengeance. We don't need to test that anymore. We've got the evidence. So just learn from what's already been shown. So, winding up, but the start of great things ahead for all of us. What are the roles that Rotary can play as a civil society organisation? And we've heard quite a lot of these already today. Fundraising, whether it be the small grants from Little Things, Big Things Grow, or it's actually trying to raise a lot more funding to put into the malaria control and elimination pot globally, working with other partners who are trying also to bring those resources together, some of who are here, some, like it was mentioned, WHO this morning, Global Fund, or NGOs or platforms that you know actually do work and can help you optimise your investment because you're leveraging off others. That advocacy role, critically important. And one of the problems we're facing in the Greater Mekong is keeping that government political commitment to keep resourcing and funding this until eradication happens, to prevent re-establishment. And many of your Rotary members are very well connected. Use those connections. We don't have them. Community-based organisations don't have them. Often donors can't deal with it, but people inside country working with their membership who are connected, they're important. Looking at emergency responses, so one of the examples I'll show in just 1 minute was filling the gaps on the Thai-Myanmar border because there weren't enough nets, because the estimation of what was needed and purchased ran out because people were crossing the borders in larger numbers than expected. So Kanchanaburi Province Rotary Group with a South Korea Rotary Group, USAID, when it was working there, the civil society platform and the academia, Mahidol University, all worked together to fill those gaps that were there. But it was against the plan, the government plan, as you mentioned, but it was filling gaps that were absolutely necessary because of emergencies. Logistics capacity, many of you know the story about the support that Rotary Papua New Guinea has been providing to the whole logistics system for bed nets in Papua New Guinea. Helping navigate things that are often politically difficult, like cross-country border meetings. We see that as a role that a group like Rotary can really help. You may have memberships either side in both countries, and you can help start getting some of those things happening. The business skills that you have within your organisation and members. In Thailand, in decentralisation, they're wanting the local authorities to be the people funding the malaria programs now. And the communities or the health workers have to apply for grants to get access to those funds. They need help to write those grants, to understand that, to have the accountability. They're things that your membership can help support. Research and capacity building, we've heard about a lot of that. I'd put also a plug-in for operations and implementation research and evaluation research, not just the very necessary bench-based and vaccines and drugs and diagnostics, but we need all of that. And when you're building capacity, also like I know Rotary Australia has done, is actually topping up scholarships to be able to have people stay to finish their PhDs or to have fieldwork money, which is often difficult to find. And then community engagement, which we've heard a lot about, how that is part of your DNA in the way that you do your work. I think we've seen a lot about the bicycles, including 65-year-old women who ride bicycles. I better get back on my bike, that's my age. But that's that Kanchanaburi Rotary partnership there. The people in the yellow shirts are the Rotary members, and they did some top-up of bed nets. They provided chemicals for indoor residual spraying and helped pay for the training of the sprayers in that work. And then there are just some photos from the work that Rotary Against Malaria in Papua New Guinea have been doing in really helping in very difficult settings where you have to use light planes, you do have to use boats, and you may have to carry them yourselves up mountains. They've really been able to help get great coverage of bed nets throughout that country. So in conclusion, to actually reach elimination and eradication, we need to have heart around equity and inclusiveness. We need to have brains around the technical expertise and innovation, and communities can be innovative. It's not just people with PhDs that you need to work with. You need to have courage to aim for eradication despite all the setbacks that we've heard about, and this needs to be done with community, and it needs to be done in partnership. Because we can reach the eradication Emerald City, but it's not over till we get there. And that's really important. It's around equity, sustainability, partnerships, and engagement, particularly of communities and civil society. Thank you.